I am delighted to be here with you. I was here 2 years ago. I think it was my first Stewards of Change. And I left energized, inspired, learned a lot. And what I'm going to tell you is what you're going to hear next are concepts that I learned here and apply, evidenced by the title, interoperability, which is really what we're about. It's not just about connecting point to point. As I say, that's good plumbing. How are you connecting to create knowledge that leads to action and improving lives, which is Live Well San Diego. So I'm going to talk about the San Diego Marshmallow Challenge and understanding that we're figuring this out just like you. And I got Don Edwards here. There's been great mentors that we've looked to learn from in Alameda and New York City Connect, work that Austin's doing on their Community Information Exchange and others. Jerry and Accenture and the work that many of you have been sharing. And I say that because, to me, I'm not the technologist, I'm not the coder, I'm not the planner. I'm the guy that's representing 825,000 lives that we serve through all of our programs at the County of San Diego, with 6,000 men and women who come every day to make a difference in improving what I call population-based wellness. And I'm going to keep pushing that we actually change the phraseology. It's not about health, it's not about human services, it's about creating wellness. And wellness is social well-being and health. And I'll explain that as we go through. Because I want to start with that slide you saw about why we do what we do. And to me,
give me a second here.
Daniel keeps it real. He's the guy, by the way, that started the naked dancing guy. That was Daniel, what, a decade ago. When we talk about being client person-centric, what does that mean? And I wanted to give you a real example, because I think we should always, stories about people's lives and why we're spending days here figuring out with our time, the people back home that are depending on what happens here and what it's going to mean into their lives are people like Donald Ryan, who's in his 70s, who has congestive heart failure, has hypertension, issues of diabetes. He was a veteran. He's multi-symptomatic. And his only wish, as you probably saw on that slide, was to sleep more in his own bed than the hospital bed. Now, Donald, it ain't working.
I'm not gonna. You want to keep talking? I'll talk in there a second.
So just, you saw the slide. So Donald's world is dealing with lots of different services and programs in the landscape, right? If we did a poll here, my table on the back, we had F&S, we had all the eligibility programs. If we did a poll here, we had dozens of different programs represented. Well, that landscape is what Donald has to navigate. And it's challenging enough for us to figure out what is the right data and the right people. Imagine a client who doesn't have our level of knowledge. And so I like to, put some Southern Italian or Italian metaphors, and I gave you that picture of Venice, right? Of people that's trying to go to the gondola. We'll pick it up from that slide where I left off. And their view there is all that congestion and traffic and noise. But the slide, okay.
Not there yet.
The slide we got up to was Donald's reality, Donald's Grand Canal experiment and experience, which is dealing with this plethora of different programs that are not navigated. And it's a creation of us, of the systems we have, that Donald is not getting the services, and Donald was getting readmitted 25% of the time at the hospital. He was part of the churn in creating the cost that you often hear about those in CMS in terms of Medicare.
Okay, you're good there.
So, thank you.
Just use the,
There we go. So, can we make the difference is the question. And when you look at these services, this is get the point earlier, many of these services, and these are real services, are human service based. And therefore, how we navigate these services really make the difference on the health side of the equation for Don. And we know this. We've seen many of these type of illustrations of silo busting, vertical horizontal integration, yada yada, okay? But it's not just at a program to program or system. How do you do it for large areas and large regions? How do we do it for the 200,000 of the Donald Ryans in San Diego that have the same challenges? And what I want to present to you is that there is a remarkable opportunity in our history right now. I tell folks, those that are in programs in social work or in public health or healthcare management, it couldn't be a more exhilarating time, because everything is getting reset in many respects. The Affordable Care Act has been a major game changer. We are rebalancing health care, public health, and human services. And we're having those conversations in all four corners of this country. And so this is population-based leadership. There's a lot of different terms. But really what this is at is leveraging existing resources in our community. Because as I see many communities, and I start with San Diego, is that we are resource-rich, innovation-poor. Many of the resources are in our communities. They haven't been aligned. And that's why I came to Sewage Change, because I saw this as an amazing opportunity to learn and bring back to my community about how do we create this alignment of not just interoperability, but interoperability in the services. Because what we're trying to do is treat not the illnesses, not the symptoms, what's the cause? In this case, and this was in 2009, we went to the Baldrige Award-winning hospital. For those that don't know, this is the best of the best in terms of operational performance. They had a hospital readmission rate about 24% for the Donald Ryans. It was sharp healthcare, a very prestigious, great institution in San Diego. But if a Baldrige Award-winning hospital was about 24, 25%, this is 2009, Donald Ryan was one of these people that were churning. So they realized they weren't solving the problem. And in great respect to Sharp, they came together and said, can we do something audacious? Like, can you help us with Donald and figure out how to just make sure he comes to his appointments? So we said, look, we'll team up on this, but we don't want to just deal with the symptoms. Let's get the cause. How many of you have gotten doctor's orders, or some of you have left the hospital? You come to your home, but think about now someone who's in their 70s, just has a bag full of medications, don't know the new settings, a little discombobulated, leaving the hospital, haven't heard half of the things they've been told on hospital discharge, and they got to get this down right. And then we get upset in terms of med compliance for the Donald Ryans. Well, what we decided was, let's bring social workers, let's bring teams. As you could see, a transitions care coach first, nurse second, coach first, social worker second. Let's work with the hospital discharge planning. Let's make sure we go through to the home setting where Donald is and help navigate his own home and make sure then he knows how to and assist him to get to those medical appointments. Well, fast forwarded, we used technology. We didn't have yet the health information exchange, which I'll talk about, that we have today. So we used a network of care, which has a personal health record component. And yes, we were able to get Donald to get onto the internet that he's never done before, to be able to communicate. another major area that we're going to have to, with the silver tsunami, have to make sure they engage more. And don't kid yourself. They all have iPhones, and they're pretty tech savvy, many of them. With Donald, we went through these kind of simple steps. It was a small grant we put up forward. We reduced hospital readmission rates for those 88 lives within 90 days from 24% to 8%. It was the best in the country at the time. It was a cost savings, net cost savings of $560,000 to Medicare. It was the human services and the alignment of the human services. And though most of this was in more analog format, this was the inspiration of how do we now create this solution pattern with technology as an enabler, because we know the business case. And obviously, what main change for us then happened a year later is, in fact, the Patient Protection and Affordable Care Act that now rewarded keeping patients healthy and safe and penalized those that were readmitted for the same issues that were truly preventable. That opened up, as I say, the hospital CEO's eyes, who couldn't probably find the nearest social service agency, and half of them didn't even know public health, to begin to pay attention as a whole. And so what I want to talk about, a couple of considerations, is I go to these conferences. I'm an integrated agency, so I go to the health conferences. I come to the Human Services Conference. I'm looking for the Health and Human Services Conference, where we're all together. And we're making an effort on that, because I know, I mean, Daniel and Shell were there, a number of you were there at the Health Data Palooza, but it's tough, right? But we have to come to that space, because the solution patterns lie within those worlds. So I want to talk about what we're seeing, what that marshmallow experiment is like in San Diego, and maybe test and push, be a little audacious, where we have to move the paradigm for us as a nation. So, the Affordable Care Act, I'm not going to go into all the details. If anyone wants more details, Dr. Julie Howe is the Senior Health Policy Advisor for San Diego County. She's here. Wave, Julie. She knows all of them. But I need the Cliff version. And the Cliff version is what the federal government really did was really payment and coverage reform. What was left, and you could see in these other titles, which falls in great shoulders of states and localities, is service delivery reform. And if you look carefully at these delivery systems, quality, care coordination, it doesn't put on neon lights of human services. But the equation, the logarithm that we need is human services plus healthcare, plus public health to make this successful. And when we have these conversations, obviously with Don Berwick's influence at CMS at the time is the triple aim. And we think this is a great model to start, but it was focused on health care happening inside the walls of institutional systems of care. They are now beginning to see that it goes beyond the institutions of care, i.e. hospitals or institutions of mental disease and others. It goes beyond those institutions. It's now the community. It's human services. So I'm going to come back to this diagram to say a little tweak that we suggested directly to IHI on what they need to be thinking about and what is driving our passion in the community. So in the Affordable Care Act, this is not just California, by the way, this is in every state, most states that are participating in Medicaid expansion. There is a movement afoot, moving from volume to value. I think there's something to be said that we need to look at this. To my friends at FNS, we've done and have been notorious about stick counts, how many people we get into CalFresh, over, under on penalties, and a lot of those kind of metrics. But I kept saying, they're missing the boat. This is the most important nutrition program that is improving health value. And that wasn't getting the spotlight. And I'm excited that USDA is beginning to look at that. So for us, even on the human services side, is looking at our programs. We look at the Title IV waiver for child welfare. It's really an opportunity to look at what we do with our funds and how we create value of keeping kids in their homes. So this is happening on the healthcare side, and they're trying to figure this out with their payment reform and data transparency and price transparency, and much of what Dr. Nirav Shah was talking about, which is phenomenal. But where's human services at? We were talking about that in my back table. It is rich with data. Had it not been for Stewards of Change, I'm not sure there would be as much a spotlight as it is today. So as we look at these requirements, and as they're moving into things like accountable care organizations, who's heard this term, accountable care organization? Show your hands. Okay. Next year, this time, all hands have to go up. And here's why. Accountable care organizations are hospitals that are aligning, and payers like managed care, and physician groups that are aligning together. And they're missing important aspects of the community called human service providers, called federally qualified community clinics, called things like public health departments. They like us for meaningful use, but they forget us on the service delivery transformation. So accountable care organizations is an opportunity where we can show value. We can show how we've improved lives for the Donald Ryans. So I won't be here on Friday, regrettably. I have to be back in San Diego. But as you think of solution patterns to what we focus on, care coordination opens up a unique opportunity because it involves medical homes, it involves ACOs. And the only way we're going to win in reducing the costs and keeping and improving the quality of life of the Donald Ryans and the Garcia families that we talked about in our case study here is really with the integration of human services with these ACO models, which we have a term for, which I'll get to in San Diego. This is a program funded by the Centers for Medicare and Medicaid, CMMI Innovation. San Diego was rewarded one of the larger awards. What we tested, that small little step that was discussed, we got to take little steps in 2009, and the lives we improved led us to an award of a 5-year demonstration award, which started last year for 21,000 Donald Ryans. It's actually, I see it as a service delivery demonstration. CMS sees it as a payment demonstration, because they want to change how payments are done if we can show efficacy in it. In our first year, which we celebrated this past January, we went from about 22% to about 12% on hospital readmissions, reduction. We're paving the way. You know what the solution was? Our Department of Aging and Dependent Services, our social workers that are working together with our hospitals on this care coordination. Folks, this is happening. This is happening. One other thing we did was that the hospitals began to see the power of this, and San Diego is a beacon community, a health information exchange, okay? So we actually use the Beacon Health Information Exchange for care coordination. And could you believe it or not, they allowed our social workers to look at the medical file. What a novel idea. But get this, we had to see the file at the hospital. So we have still a ways to go. My point, though, we began to create that team-based care. They began to see the importance of the data that social worker was collecting in the home, and those discharge records and the care being followed with their primary care doctor and in the hospital. The insights and the aha and the epiphanies were happening. And that's with a health information exchange. Of course, I'm using that in San Diego now, as you'll see what we're trying to build out, is if all we have is a health information exchange, I call that a unicycle. If all we're collecting is the connection to all the hospitals and the clinics and public health on meaningful use, it's only a unicycle. We need also the back wheel, which you know what I'm talking about, is what we're creating here. And it's the connection of those two wheels to create that bicycle. And the frame, well, I think I have an idea how we're going to create the frame to connect those two. So I'm going to skip this just to highlight one key aspect. We're moving more transactional to transformative. And people say, buzzwords, show me, prove me to. I'm going to prove that to you. But it's the one, as we get to connecting the unconnecteds, to thinking about interoperability. I never hear in this conference it's about just connecting people. I hear about it's connecting people, and it's putting the people in the middle, it's making sure they have their data, it's connecting the providers, and it's about improving the lives of the people we're touching. That's what I hear. That's where we're going. In many respects, we are ahead of the pack on the vision than where our good healthcare colleagues are going with their health information exchange. There's still more in the interoperability connection, saving money, making sure knows what, search and query type stuff. We're going beyond that. And that's value that where we would add to those conversations. But it's also the last one. Moving from sick care and social welfare and all the stigmas attached. And I don't know if you know this, San Diego is a conservative place. We've balanced now in our geopolitics. We added our first Democrat after 20 years on the County Board of Supervisors. A supervisor who's adopted 6 kids in our county foster care system. An openly gay, married supervisor with 6 kids who adopted in our system. And Dave Roberts is a big supporter, as now the board, to see that this is not about the stigmas. This is about wellness. So if you can get the Tea Party and have an audience this big and talk to them the value added through wellness and not get caught up on the phraseology of Obamacare or healthcare or welfare. It's about wellness. That's why that's so important, because it's an enabler for cross industries and people to come together. Because I'm still looking for that person who doesn't want wellness. I haven't found that person yet, but everyone wants wellness. That's something everyone wants as almost a right. Well, that's why we're focusing on the issues of wellness. And you hear San Diego almost ad nauseum talking about wellness and wellness. It's not code. It's really trying to change the vocabulary and the mindset of what we're trying to do. So I think you know about San Diego as a community. We're broad, we're big, we have a lot of challenges, as many of your communities. We got a little more sunshine, but that's okay. But other than that, we have, just like anybody else, the challenges in our community. And I think one of the things for us as an integrated agency has been our experiences, right? All of our experiences where we come from. As I immigrated to this country as a young kid, not knowing a language, being on, at that time they didn't call it, we had food assistants, right? Those block of cheeses and stuff. And my nursing care was the parish nurse, who weren't friendly, mind you, and terrifying with those big hats. As an inner city kid, our experiences bring us to where we are. Well, as an organization, our experiences bring us to where we are. And this is where it's important to understand welfare reform to health reform change us. We have made remarkable strides during the Clinton administration on welfare reform. So these bookends of health and welfare reform are things that shaped us and how we look at our eligibility systems, how we look at families, how we've looked at communities, how we've thought about the economy and self-sufficiency. Add in their natural disasters and how that prepares us in our resiliency and how we respond, it shapes us. So for San Diego, when we were created, it was all for the wrong reasons. We were just behind Orange County to go bankrupt as a county. And for the record, I wasn't there yet. This was 1994. But they were going to declare bankruptcy, and what they did was create this super agency, and I said this to Don, all for the wrong reasons. But oh, am I so glad that they did. They did it for cost-saving measures. And they called it the no wrong door, we're going to make sure not anyone comes to any of our services. Yeah, but it wasn't the heart and mind, if you know what I mean. It was more of the wallet. But I was there with Dr. Ross, who's with the California Endowment today, and when I was there from the beginning, and what we created was this opportunity that we saw that there were services across our agency that the right didn't know from the left. We've been dealing with this, we still deal with this across our departments. This is not new. But it changes after now 17 years when you're at the head of the table and you have your department heads saying, we have to win on wellness. The data is not yours. You don't own the data. And it helps when you're married to an attorney. When they say no, 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 you wear them down. They say, listen, we can do this. Our experiences change us. And when I was given the privilege of being the director in 2008, it was a decision point, maintenance or development. And thank God the board chose development. And we took the journey of Live Well San Diego. And I'll hit on some of the key points here. And it really was, if you're familiar with the Harvard model, the human services value that Antonio does at Harvard, which is remarkable, we were wanting to move from this regulatory state to a much more collaborative state at that time, to where we are, I think, more today, more integrative. But there were key things for us, just things like we're dealing with now: the business case, the economics, the politics, policy reforms that change our sandbox, opportunities and challenges, technology, and culture change. And culture change both for communities, the people we serve, and the workforce. Well, all of these things really influenced us. And we realized this was bigger than us. We also realized that the old solutions weren't working. Just like hospitals were trying to fix readmission rates by themselves, okay, it wasn't working. And I have to say this, with all due respect. In the presence of violence, you're not going to achieve health. Having lived and worked in inner cities, Newark, New Jersey, we could see this in our own communities. If you don't address the issue of trauma-informed, if you don't address the issues of violence, you won't get to building better health. So this is even more daunting. This is more reason why we need NEAM, more reason why we need to have that type of partnership and data exchange. Because a social worker going to visit a home in a place that's not safe, it would be misleading and inappropriate for that social worker to kind of scold that family why they're not exercising or doing more activities when they're worried about their own safety in their community. So we really put ourselves out there and said, we need to do this over 10 years. And I say we, this is the Board of Supervisors. This is their plan that I'm espousing on their behalf. And we said we have to look at this broadly on the health side. We have to look this broadly on the safety side. We have to do it on the thriving side. And the thriving is about economic resiliency. How do we get people access to nutritious foods, jobs? How do we do a housing-first health home model? Because someone who's homeless is going to stay homeless if you don't give them shelter first. So these were quite challenging areas for the board, because this is not something San Diego's done before. So it's not like we've been doing this forever. Our path really, and there's been a lot of great groundwork, but our path really started in 2008. And we're looking at this from a braided perspective, and we're realizing, again, that well-being goes beyond physical health. And this is where we get trapped, right? We create our own mindsets of how those spaghetti things have to be together. We need to think out of the box. And for us, our out-of-the-box thinking is that well-being is emotional well-being. It's about people connecting in their communities. It's about civic engagement. It's about I'm getting recorded, the poor turnout that we had yesterday in San Diego with our local elections. It's actually embarrassing as a civilized society. We should be off the charts with people coming in and voting. How do we restore that confidence in the public? But that's a measure, we think, of well-being, of people taking pride in their community, because we're going to need those communities to stand up on a lot of the solutions that we're asking. So, potent simplicity. Things are so complex. and I have to explain this to my board, so usually it's 3rd grade, 4th grade level. That's, for the record, that's not saying my board is at the 3rd, 4th grade level. I'm just saying understanding level, right? But what really we're looking at across building better health, living safely, and thriving is these 4 things. It's building a better service delivery system for all. And I always say for all, because when you say you're building a better service delivery system, then I always ask for whom? Because we got to stop the tiers or us in our service delivery systems that we have in this country, in our communities. How do we provide positive choices with my great friends in New York City? We're not about big government. We're not going to take you big gulp. We're not going to take you chunky monkey ice cream. We're not going to do any of that, okay? We're not going to take the trinkets away from the McDonald's stores, because those have been attempted, and child obesity rates have risen in those areas. But what we want to do is that when people come in and are on CalFresh, and that's SNAP for those that are familiar, that we're also bringing in public health and our educators to help those families with culturally appropriate education around healthy eating. That's what we will do. Give them choices, work with our community partners, develop resident leadership academies to let the communities take more charge. That's what we talk about, positive choices. Policy and environmental change, you've heard health in all policies. Well, we like to say health and safety in all policies. This is remarkable stuff we've been doing. I told my mom, I was so excited when I built out my first sidewalk, because we received community transformation grants, and we spent some of our money working with our government associations to build out sidewalks, because kids in our South Bay were getting hit by cars and therefore weren't walking to school. So our solution about getting kids healthy was dealing with safety, and it was building out sidewalks. Huge policy issue that place matters. So policies is a key issue. That's at the county level, but we're talking here policy alignment, state, federal level, international level, right? And then culture from within, walking the talk. We are 4th largest employer in the region, and if we were going to ask people to be healthy, if we were going to ask people to be trauma informed, if we were going to ask people to support policies in their own businesses, we sure better act that way. So we are doing that. And I did a memo just even a couple of months ago saying within the next 2 years, all 6,000 employees of the Health and Human Services Agency will be trauma informed. Asking the simple question, are you okay? I don't know if you know this. Many parts of our country today, if you come into an eligibility office, we don't reimburse for that, and therefore we don't ask that question. What do you need? How can I help you? That's it. When people are dealing with trauma in their lives. And we know the detriment that has in their longevity based on the ACE study for kids. So we're asking the question, are you okay? And then taking action when they say, no, I need help. These are the type of things we're changing in our own behavior that we need the Office of Personnel Management, for my federal colleagues, to do at the federal level. And we're working with them to also lead by example, the largest federal employer, to do the same. All right, you know this, we don't work alone. And clearly when we're talking about patient-centered care, the question that always hits me is, well, who ordained you to kind of lead this? And I just want you to know, it's the naked guy. You know, when Daniel had his first moment here, people saying, so this guy ran a cookie company. What was he doing? Cookies? Bisco? What was it? What does he know? And he only probably didn't have a crowd this size. Am I right, Daniel? But he was the shepherd. He was the courageous, bold shepherd that had the vision. All of us are those shepherds in our respective areas, be it industry, government. And it doesn't matter if it's government or United Way or a nonprofit, health system, group home. It doesn't matter who the shepherd is. Important is that the shepherd is a good shepherd and bringing people together and convening and not fearing the worst. because then nothing happens in communities. So for us, here is what I want to get to, because it's about interoperability. We are shepherding a process which we call the San Diego Knowledge Exchange. We were one of the 17 beacon communities. And that was terrific. Health Information Exchange. The money came and gone, 3 years. And I'm proud to say that it's still standing. And actually, we're beginning to exchange data between hospitals. What a novel idea. I believe if you can do it with hospitals, you can do it with almost any other industry in the world. When you showed me CEOs, I bet you those wasn't hospital CEOs. I love my hospital CEOs, they're great, but myopic, okay? And so they're now uttering the words population-based healthcare management, because they can't say public health. That's the nexus of what they do to population health, right? But the point is, they've begun to appreciate what we do around human services. They've begun to appreciate things like 211, a huge utility in many communities, not all, of service that's connecting knowledge, people to services, but it's making and collecting knowledge, creating knowledge for providers. But there was, as I said, the back end. We needed to see, and now with NEAM, the ability to share among human service providers. And so I'm proud, going to a local foundation, having them and asking them to stand up $2 million to create a community information exchange. And they stood up the money. They believed in this and are now creating a plethora, starting originally with about 24, social service providers coming together, developing that interoperability with the intent of exchanging it with the Health Information Exchange. But one little thing is that you also need government in there. So we quickly realized, and I'm not going to belabor these slides for time, but for Health Information Exchange, they're sharing it. There is no depository. It's a repository. It's basically search and query kind of model, because they don't want, God knows if there was a database that had everyone's record in it. And the Community Information Exchange took that same approach. Well, we got to follow because the hospitals won't play, so we can't have a database. So we got to do the search and query kind of concept. That helps, at least. And 211 does have a database, but it's the database of the providers. It doesn't collect information of individual clients, per se, both on its web and its call center. So someone had to create a database. Someone had to be the frame of the bike to connect the wheels. And that's what we're doing in San Diego. We call it the Knowledge Integration Program. Some of you have heard about it. Kerry Hoff has spoken before. And this is where we see utter importance in not waiting, no offense, for others to tell us or a promise this is going to get done. Because we have 825,000 people that are counting on that we need to make sure we get the right service at the right time for the better outcome that they're getting today. So KIPP is a look up and search. It's a referral management. It's a collaborative service delivery connecting with our hospital partners because of meaningful use through public health, as well as information exchange through the community, the CIE. But it's the population-based shared analytics. How many times do our workers go out there and they're blind? Yet, if we had the application of machine learning, yet if we had the ability to look at the past and give them insight on to make that referral or to make that removal or to provide that medication, we would save lives and save money. And we know this from our own, and counties know this, in our own errors that we make and what we pay out. But it's the lives of people that count. So when I had this conversation with my board of supervisors, all 5 of them, and individually, I explained that this was really about, first and foremost, improving lives. It wasn't about saving money. But with it, I gave them a couple examples of errors made that were completely preventable. Errors made between our probation department and our child welfare. Errors made between our public health clinic and our child welfare and behavioral health that were completely preventable. So we talk a lot about medication errors. We talk about those casualties in the hospitals. Where's the errors made in social services? Who's capturing that? There is nobody. And can you imagine what that would look like if we were to able to capture that? It sure would support our efforts and justify why we're doing what we're doing. So I use concrete examples in San Diego of why we need to build this architecture, why we need to innovate, why we need to have this regional information exchange that's not just plumbing, that's really generating knowledge, improving lives, putting the person really in the middle, making sure the person can also access their data. Hospitals don't like that yet, but hey, that's the new law. Making sure that people have access to information and knowledge, making sure that what we are developing is also strengthening organizations and their ability to better serve clients. This regional approach goes beyond government. It really is business. We have for-profit hospitals part of this. We have nonprofit organizations. We have the City of San Diego's Emergency Medical Service and Fire Department. That's part of this. We have a lot of non-traditional partners, as well as our traditional social service agencies, part of it. We believe that this shared belief of individuals and resources create healthier, safer, thriving communities. Now, I know some of you are saying, this is a great depiction. We've seen a lot of these other bubble charts. Show me. And this is the structure that we're standing up in San Diego. And so on the beacon, on the Health Information Exchange, we got results, real results, of where health and social services came together, improving lives, saving money. Now we're beginning to put these other pieces. And the key for us is, this is how it is today, and it will be with KIPP in about a year or more. But we got these programs coming in these funnels, and they're providing all these different services, and 211's trying to map out who does what. But where we want to go is one funnel. This is our audacious marshmallow experiment that we're trying to create. And frankly, all these slides you just saw, I brought in the Health Information Exchange, the Community Information Exchange, and 211. We've been doing these joint presentations together to the Ford Foundation and the recent study they did on interoperability human services, to our chambers of commerce, to my elected officials. We're speaking with one voice. So I don't want you for a second to think these are my grandeur ideas. This is the public-private partnerships ideas that I'm presenting on behalf of San Diego. So what excites me is, this is our services across the lifespan in behavioral health. And I was debating whether to have this, but having spent the whole morning dealing with our recent elections and mental health parity and issues with our current elections, I figured I'm going to include this. And the reason why is we had a foster youth, emancipated foster youth, as an adult, who did harm to himself and others. Not an uncommon story. And the reality is, we have these people from birth to seniors in the lifespan of these folks, but our systems don't talk. Even within behavioral health, we don't have the systems that are integrated. Never mind probation, never mind child welfare, never mind education, never mind law enforcement. And so this was an eye-opener experience for us. I know something happened in Virginia. Every state, we have this going on. This is an imperative, because this is the lives of people that come through our system, but the information backbone is not there. And what we know is that had we known between the right and the left, we would have kept the continuity of care for this individual. That unfortunately was lost. So the roadmap, and we got to get to dinner, because I can keep going on to this. The roadmap for us is really building the relationships. It's about people. And I said this too, we had a codeathon, wonderful apps. You can have amazing maps. Isri does phenomenal work. But if you don't get people to take action on it, it's all for naught. So how do we create a movement? So let me get back to that little thing called wellness. We've had cities that for the past 2 decades were mudslinging with the county, never get along, nothing, everything, transportation, water. Who would have thought that they would have joined forces on wellness? Our most conservative cities, chambers of commerce, schools, they love this stuff. The electeds, the community people, they pass their own resolutions to take on the tenets of becoming Live Well, which is about no money. Ladies and gentlemen, make it clear, it's not about any money exchange. It's about leveraging. It's about cities using their libraries aligned with promoting during May on Foster Care Month. It's about fire stations doing blood pressure screenings. It's about schools opening up their fields so the community nearby can use. These are the assets that exist that we're leveraging. In essence, it's creating this movement, and it's large scale. And coming together on this with purpose, and I'm going to forego the accountable care community slides, but it's how does everyone have accountability? How do we move to this accountable care community setting? If you remember, I said, how many know accountable care organizations? Right? A couple hands went up. Here's the cool thing. It's not about organizations. It's about accountable care community. The National Association of Counties, Emmanuel's here, is leading that effort of having the conversation about accountable care communities. How do we get everyone together? Sid Gardner's been talking about this for decades. This ain't new. This ain't new, right, Sid? Ain't new. But how do we now get the non-traditional people to come and support this? And I think it's about vision. I think it's about Neil Halpern's model, if you're familiar with it, from UCLA, looking at where system transformations, delivery systems are going. He got up to 3.0. And when I asked him where are most systems, health systems, and the criteria, on his criteria, he said mainly in 1, maybe some in 2.0. Very rare few are in 3.0. And I said, well, but there's something missing here. This is health-centric. And so if you look at the bottom and in bold there, that's too small for you to see, but I added a couple things I felt were missing, which we affectionately called it the community wellness system, not the 3 or 4.0, but what we're doing. And it's about rebalancing health and social services. It's about intergenerational caring communities. It's about those resources that are trapped that we know and we work with that haven't been integrated and aligned. He was pretty excited about this and wants to publish this, but wants first a community that can stand this up. And no, San Diego is not at the community wellness system level. No one is. We're striving. We're trying to get there, like everybody else. But remember I said we're going to come back to this Institute of Healthcare Improvement? Well, I think a future panel should be Robert Wood Johnson and their Culture of Health movement, the IHI with AAA 2.0 with a little tweak. It's not just about improved health, it's about improved health and social well-being. Now, I figured what to lose. They were in San Diego at a conference, invited me to speak. I figured if they booed me, I'd just go to my office, didn't care. And I presented this to them. Dr. Howe was with me. And these were all health people, hospital systems. They ate this stuff up. They said, how can we do this? And they were asking for you. They were asking for you. They want you. They want this. They realize this. So creating this table, and then how do you measure? Because you can have great words, but I say is, don't trust my words, believe my deeds. look at the results. And we developed an evaluation framework because our board was demanding accountability every year coming back. And this is our 4th year in our 10-year plan of how we're showing the alignment of partners taking community action and managing expectations. Because that's the other thing is, this is going to take time. But we're beginning to show the short-term, the mid, long-term impacts. Beginning to define audacious things. Yes, we're holding ourselves accountable to life expectancy and quality of life. Shouldn't we? Isn't this what it's about? We're holding ourselves accountable to improving knowledge of people and communities. We're holding ourselves accountable for unemployment, income, safety. And here's the issue. When I first presented this, it didn't go well. Because the immediate response is, I don't control that. But I said, wait a minute. But we're part of that accountable care community. This is for all of us in the region. And when you become a Live Well partner, we share this and say, do you believe a centered set philosophy? Do you believe in these things? Because this is where we're holding ourselves to achieving. And I have to tell you, there hasn't been a single person yet that says no. And we've had some just amazing diversity of people that have enlisted and joined. And so we are showing results. We're telling the stories of how we're reducing childhood obesity, heart disease, and kids in foster care. How we're making a difference in the lives of children across. And standing up, information. Everyone has a website, so we have a website. But it's not the website. It's not the website. It's this. And the punchline is really the bottom. Getting the public to believe and engage. We spend a lot of our time with policymakers and payers. I took a different track. My track was getting the public to say, as constituents, we want this, we need this. And getting them to join. This is a very difficult. This is why it's not a plan. This is why it's not interoperability. It's interoperability. It's a cultural movement. It's done with great humbleness as government. It's about public-private partnerships. So I wanted to share this story because San Diego's not alone. There's a number of you I know in this community that are shoulder to shoulder leading this effort. And what excites me is that Stewards of Change here is that part of the equation for us of how we're going to create that bicycle of knowledge and then measure the impact in the lives of the people we're serving. Thank you. One minute, I think, left, so we got to go. Strategically did that.
I have some questions. Well, I've never given you questions in advance of the presentation because you answered everything that I had thought up to ask you. So I was able to write down a couple of more. But before I go there, I mean, clearly, I think we should open it up and let the audience start asking questions. Go ahead, Richard. And then Ivan.
Nick, there's been a lot of discussion about the failure of the Veterans Administration and the healthcare. I know that you're very familiar since the military installations in San Diego. I haven't heard anything about human services and where human services can play a role in reforming the Veterans Administration. I would hate for this kind of opportunity to pass without it being used to bring together community human services and community health?
Fantastic question. We have about 600,000 men and women who are active duty veterans and families of active duty and veterans of San Diego. We are and have at the table not only active duty, Balboa Naval for us, but the VA administration. We're developing what's called a Military Veterans Civilian Coalition. Let me give you a concrete example. And my good dear friends, Virginia Commonwealth and us in San Diego got together, Mike, was it a couple years ago, having these conversations, learning. I don't know if you know this, that in the military, in TRICARE, they measure and they track immunization for children of families, of military families. It's not shared with the civilian side. So in San Diego, we have one of the very robust, we started some time ago, a very, very effective immunization registry that doesn't have the military children in it. So I felt that was important. We were over-immunizing kids because, believe it or not, military children come also to the civilian side, about 20-25%, and they have no record of it. So this I consider a no-brainer. This is like kids' lives, sharing data. So I went to BUMED. I went to the Bureau of Medicine at the Navy, as it was primarily Navy, and said, we got an opportunity for you to save money and improve the lives of the children of our enlisted. And I hate to say this, and we haven't given up, but their view was, well, that's your system, we have our system. So as we're also talking about interoperability among our civilian side, there is a whole nother parallel track with the military and the VA. I use that as just one illustration. There's others. Project 25 Cities, I don't know if you know this, President Obama put, this is now before what happened with the VA administration, but last December, top 25 cities to end chronic homelessness in veterans by 2016. Well, how you're going to end chronic homelessness by 2016, by the way, with no money from HUD to do this, is a housing first health home model. So we're not looking, no offense to the feds, for that solution. We're part of that effort. But what we are doing is looking at our Section 8 housing. We are doing slots dedicated to veterans. We are doing our wraparound of our behavioral health services. So they are a key piece of, if we're going to say we are living well in San Diego, that is a key piece. But that's another area, another domain that we're going to need to really focus on, the interplay between military, veteran, civilian. So thank you. Great question. Yes, sir.
Go ahead, Ivan.
I'll speak loud.
Okay. She's coming.
So one of the things some of us have been discussing, and I think fits right into what you've been saying, is maybe one of the ways to get these things to happen and to show the efficacy is to start using measures, cross-domain measures. For example, the effectiveness of housing programs, there's a lot of ways of measuring it, but the health of the people who you've got in the program probably could be a good measure of how effective the program is in terms of the cleanliness, the environment, allergens, so on and so forth, and vice versa. Maybe if, at least for predictors of health, if we were using measures that were outside of the healthcare system to, in healthcare, we would start getting people to get the message that these things are connected concretely and to start making some program, to start making these connections, because we'd be starting to show people this measure here indicates that you've got to do something outside your domain.
Spot on. How I got, no one asked the question, but how I got Alliance, it wasn't from my ugly looks, how I got the Alliance for Healthcare Foundation to give $2 million to create a community information exchange is that a year prior, we took our 25 top frequent users, some of these people, ED visits, I kid you not, 67 times. Those 25 chronic homeless individuals, we spent on direct health medical care expenditures, $6.7 million. 25 people, $6.7 million. We got together with the city. I brought in my behavioral health. In this case, they were mainly in the city of San Diego. We did a housing first health home model. We got all 25 off this street. We went down to, I think it was $900,000. That's the type of power of data. And said, we did that the old-fashioned way. Memorandum of agreements, permissions, analog, fax machine. We need a system where we can really have the 360 perspective on those 25. I have 8,500 homeless people living in my county. That's just one segment. So absolutely, that's what approach we used of demonstrating the business case, showing the value, technology's enabler.
Hi, Emmanuel with NACO. Just to piggyback on what Nick said, the housing piece and the ACO, ACC piece is so critical. And for those from smaller communities who think it's not scalable or they don't have the funds, other counties across the country are doing it. Summit County in Ohio, which is the Akron area, has 500,000 people. They've had a tremendous turnaround, and they've gotten everyone from their national parks, from the National Park Services on the federal level to the transit system on board to connect the unconnected, whether it's to lower the diabetes rate, bring economic development, and so forth. And on the other side, for even tinier communities in Minnesota, Olmsted County, they've built that information exchange and they're building this community, but their issue, as they will tell everyone right now, is housing. They have this great system, they've gotten their justice and law enforcement on board, juvenile justice system in terms of the kids who are using services, but the housing piece was been missing, and so now that's the most critical piece, and they feel like they can't be successful and get to where they need to be until they have the housing piece. And I guess another community that I would take an example of is Hennepin County on the ACO side, which is the Minneapolis area of Minnesota. They had the top 4% of people who were using the Medicaid in the county, because it's a county administered state in Minnesota for Medicaid. We're eating up 64% of the county's Medicaid funding, 4% of the top 4% users. And so what they did was that they honed in on those folks who are their chronic users, their high flyers in the hospitals, and they brought all those wraparound services, and then it really, they've seen it anywhere from 40 to 95% drop in the cost per person from those 4%. So these are, they're all around you. I guess sometimes counties are not very good at talking about themselves and highlighting their work, but just again, the housing piece and really getting everyone on board and not having that talk about money really is very helpful.
Let me, if I may, just on that, just leave you two things. This is something I hope you could do, and if you're at the federal agency, I think it's insight to have, but for those that are coming from states and local jurisdictions, public health accreditation is happening. They have to do health impact assessments. In our region, we made sure that human services was part of that review. This, I didn't talk enough about, but just to say, this is a wonderful opportunity as public health is going through accreditation. We have 3,000 public health departments in this country. There's one near you, I'm sure. Ask the question. Don't let them make the same mistake that we did back in the 60s with Medicare and Medicaid and the institutional care we call sick care today. This is an opportunity as they're beginning their journey on public health accreditation to talk about where is human services tied to that. So that's number one. Number two, every hospital in your community that gets Medicare and Medicaid has to demonstrate community benefit. There are new IRS rules that I wish, Daniel, maybe next year you can have to come in and talk about this. I could not get the hospitals, after we demonstrated the 6.7 million down, I could not get the hospitals to fund some of the housing supports to get to hundreds more, even though it was avoiding them from going to the hospital. Here's an opportunity, though. All hospitals have to do community benefit. They have to reinvest it. And the things they used to do in the past, they can't do it now, which is kind of finding unique ways of, let's just say, reinvesting back into the system. Now, it has to show real community benefit, and attorney generals are paying attention to this. Here's a way to come as a friend. Here's a way to say, hey, Have you thought about, for example, since you have to, by the way, I hear this thing, community benefit, you have to support things in the community, how can we help you help us around care coordination, around the homeless? If you're not knocking on their door, they don't know who you are. If you're not knocking on their door, they don't know who you are. And you are part of the value equation in this. So something to consider that you can do that's there now, we could take advantage of, that I encourage you to do. Michelle?
We had one more question in the back, and then I think we can wrap it up.
Thanks. It seems like the beginning of the process in San Diego was a catastrophe, essentially bankruptcy. And one of the previous speakers basically said information sharing started, of course, with 9/11. Do we need to all go through a calamity, or do you think the Affordable Care Act or some other initiatives like that will prove enough of a strong foundation for the rest of us to build on without a calamity?
Yeah, that's such a great insight. Well, my view is you never lose a good disaster for, to that. Here's the reality is we have disasters happening in every one of our communities today. What's happening to children, what's happening to elderly, what's happening on the front we're losing on chronic disease. We have disasters beyond, much more scalable and larger than natural disasters. Are we seeing what we're not seeing? And then having and framing that conversation and framing the table to begin to have that courageous conversation of what that means. Daniel alluded to the 3 for 50, and he's ad nauseum. He's seen it so many, I didn't even include it. But 3 lifestyles cause 4 chronic diseases that lead to over 50% of all deaths in your community. What community are you from? In Boston, the great Boston Strong. 3 for 50 is happening. And those 3 lifestyles is poor diet, lack of exercise, and smoking. And your 4 chronic diseases are cancer, heart disease, diabetes, and respiratory diseases like asthma. 75% of those chronic diseases are preventable. San Diego, we spent $4.7 billion on direct medical care expenditures on those 4 diseases in 2010. And we spent $1.2 trillion as a nation on those chronic diseases in 2012. I would say that is a disaster. So we all have those issues. And the question is, what are we going to do about it? And the traditional healthcare approaches haven't been able to fix it. This is where the equation of what we do broadly with public health and the economy, that's going to make the difference. Thank you.
Before we thank Nick with a raucous round of applause, let me just say that Nick, you remain a committed and enthusiastic and a role model for all of us to be trying to emulate. I threw a bunch of questions at you before you put together your presentation. I jotted down several more. You've answered all of them without me even having to ask them. And I would go so far as to say, you even, my last question I thought, aha, I'm going to get him on this one. He's going to have a question to answer, was what is the secret Nick sauce? And you even told us what that was. If you're not knocking on their door, they don't know who you are. And I think that that's a testament to not only perseverance, but courage to get out there and be having those tough conversations with people and continuing to have them. And I think that as we look towards, I know at my table we've been talking about what are the 1 or 2 behaviors that we need to have, and we had a little chat about this yesterday at the Palooza. What are the 1 or 2 behaviors that are going to change people's way of approaching this so that we're no longer talking about it, we're now doing it? And I think you just gave us a hugely valuable insight into at least one of those. So thank you very much.